second, ערב טוב לכולם, אנחנו מחכים שכולם ייכנסו למפגש מרתק נוסף של מצנתרים בנעלי בית. אני תכף אציג את החברים הנכבדים שאיתנו, נמתין ככה עוד איזה דקותיים כדי שאנשים ייכנסו. אני יודע כבר עכשיו למדפוינט ולמטכניקה על התמיכה הנהדרת במפגש הזה, ואני מקווה שיהיה לנו מפגש מוצלח. נמתין עוד איזה דקה או שתיים כדי שאנשים ייכנסו ונתחיל מיד. ושוב, תודה שהצטרפתם. Did you like it, Paul?
I did not understand a word of your Hebrew, but I'm guessing it was good.
Yeah, that's the main idea here. Okay. Do we have Elliot here? Let's see.
Not yet.
It says that he has no audio, trying to fix.
Okay.
Professor Dannenberg is online.
Well, I'm thinking I'm the first speaker, right? So
yep.
So maybe you could solve issues with Elliot.
Yeah, we'll definitely do it. I think that the chair of our working group wishes to say a few words. Let's see if Professor Dannenberg is in the house.
Yes, I am. And thanks for the invitation to open up, sir. With your permission, I will move to Hebrew for a minute. חברים יקרים, ערב טוב, אני שש לפתוח את המפגש הזה של מצנתרים בנעלי בית, בהנחייתו של דוקטור מינכה, המזכיר הנבחר של החוג לקרדיולוגיה התערבותית, ואני גאה לברך אותו ואת פרופסור איסי ברבש, הנשיא, היושב ראש הנכנס של החוג לקרדיולוגיה התערבותית. אני חושב שזה צוות יוצא מגדר הרגיל, להיכנס לנעלי הבית הגדולות שאנחנו משאירים להם. בנוסף אני רוצה לברך את דני דביר ואת אייל בן אסה שמצטרפים לוועדת ההיגוי של תוכנית המפגשים הזו של מצנתרים בנעלי בית. גם בימי הקורונה אנחנו משתדלים להביא תוכן מדעי ומפגשים ברמה, ואני חושב שההיענות הגבוהה וההתלהבות מהמפגשים האלה מוכיחים שכנראה אנחנו בכיוון הנכון. אז לחברי הוועד הנכנסים איסי וסער, ברכות. איסי בעצם ממשיך בקו ישר ממזכיר ליושב ראש, ואני בטוח שעוד נמשיך ונעשה גדולות לקרדיולוגיה ההתערבותית בארץ. אז בהצלחה, סער, תמשיך להוביל.
תודה חיים היקר. Let's rock and roll. So, we have a great evening ahead of us, and without any further ado, I would like to introduce our speakers for tonight. So this is going to be a CTO-oriented program, and our first speaker is Professor Paul Knaapen. Professor Knaapen is an interventional cardiologist with a history of non-invasive imaging with cardiac CT and PET. He has specialized in bridging the gap between non-invasive imaging and invasive diagnosis and treatment. He runs the CTO and CHIP program at the AUMC in Amsterdam, has a lot of experience in a lot of cases in proctoring, a faculty in AUMC Amsterdam, followed by a talk by Dr. Elliot Smith, who is a consultant cardiologist at Bart's Heart Center and the Royal Free Hospitals, London. He leads the complex coronary revasc and CTO program at Bart's and interventional proctor for CTO PCI. And last but not least, our own Dr. Ilya Litovchik, a senior interventional cardiologist at Shamir Medical Center, the leader of the CTO and structural intervention program and a proctor for chip and intravascular imaging of physiology procedures. And again, thanks for our sponsors for their kind support. And now, without any further ado, Professor Knaapen for his first talk. Thank you, Paul.
Yeah, thank you, Sarah, for this kind introduction. And I'd like to emphasize that I really welcome this opportunity in these sort of difficult times to sort of engage in these endeavors. And also, I'd like to emphasize that I've been working with you and Ilya in your lab for multiple occasions, and I'm really looking forward to coming back and when the world is opening up. So it's not just that we're just meeting for the first time. I mean, I think we're really close companions and friends and colleagues and brothers in arms. And with that being said, I would like to share my screen to my presentation. And I have not been given an easy task to talk about the evidence of percutaneous coronary intervention of chronic total occlusion. Sarah, could you please confirm that my screen is online?
Yeah, you're good to go.
Okay. So because in terms of evidence, as with any PCI and stable coronary disease, there's very little, but I'd like to take you through it in the next 15 minutes or so to talk about it. So we know that by way of background that chronic total occlusions is defined by a total occlusion either estimated or documented for at least 3 months. And that is not a rare finding. It happens about 1 in 5 patients in whom we have obstructive coronary artery disease. And so it's a relatively common product. However, we only do PCI of them on a global terms in about 10 to 15%. So these are patients who are undertreated. And this is predominantly because of the fact that we have low success rate. And this is about 60% in antegrade wiring and even in selected patients. So it sort of makes sense that we sort of gone down the road of walking around these patients as opposed to tackling them. So we treat them differently. We offer them less frequent PCI, more bypass surgery, or just nothing at all, in which we call optical medical therapy, which is basically doing nothing. And there's one fundamental aspect to it. It's because PCI of CTO is difficult. If we cannot achieve the goal that we want, we tend to maneuver around it. So I'm not going to tell you about this whole fable about the fox and the grapes, about the fox wanting the grapes, and he's really hungry, but he imagines them then being sour to walk around them. It's simply an analog to what we have with CTOs. If CTOs were treated very, very easily percutaneously, we would treat them the same as any other obstructive coronary disease. The fact is they're not, and we make up excuses why we should not. So we have clinical cardiologists who back us up and say that collaterals protect the patients from ischemia, which is not true. Optical medical therapy is sufficient to manage symptoms, which is not true. PCI is not proven to improve outcome in patients, which is true, but it's also true for any other type of stable coronary disease. And it's dangerous, which can be true, but in a good center is not true. So I show you this picture because this is a patient on the left-hand side who has had a CTO and is not being treated, and he will live the same life as the right-hand patient, which is the same patient, but is now running marathons after a CTO procedure. So basically, we're doing this for quality of life. The left patient is being impaired, the right patient has a successful procedure and now lives long and prosperous to the Tel Aviv Marathon. So, referral for PCI. If you take a patient on the left-hand side, this is a subtotal occlusion of the LAD. His likelihood of getting PCI is close to 100%. This patient on the right-hand side, who has the CTO, has the likelihood of getting a PCI in the proximity of 10 to 15%. Whereas they have the same disease, they are the same patients, but we treat them differently. And the only fact is because it's more difficult to treat. So we, as an interventional community, should tackle this problem and try to treat these patients better with the current scope of technical armamentarium we have in the skill set. So why should we do PCI-CTO? It's relief of angina, it's reducing ischemic burden, it's potentially restoring left ventricular function. We have the concept of double jeopardy. If you rely on a donor artery and the donor artery gets an acute coronary syndrome, your prognosis is worse. You reduce the event rate of coronary bypass surgery, which is obviously in the best interest of the patient, and you may even improve survival, even though we don't have randomized trials. So my talk was about the evidence. Well, the evidence is that CTOs are ischemic. And this has been documented a long time ago by Gerald Werner, already published in European Heart in 2006, documenting that in every patient in whom you measure fractional flow reserve, it's below 0.8, it's below 0.5, it's below 0.4. So all patients with a CTO have ischemia. There's no debating about it. It's simply documented. We have reproduced these data, and we published this not so long ago, but also that the ischemia is reversible. If you take a look at our PET program with the oxygen 15 labeled water, 95% of our patients have ischemia in over more than 10% of the myocardial territory. But also, if you treat them, it's completely reversible. If you take a look at this ischemic defect after treatment, this ischemic defect in after treatment, and these are not anecdotal reports. This is just common day practice. More than 95% of patients have ischemia over 10% of their myocardium. So that combined with symptoms gives you justification to treat them because you will alleviate ischemia. We know from back in the day from Hakamovich and other people from Cedars-Sinai centers in Los Angeles that it may hold prognostic benefit if you have like more than 10% ischemic burden, that medical therapy is supposed to be inferior to revascularization. We simply don't know, especially after the ischemia trial. But the COURAGE trial has led us to believe that if you have a large ischemic burden at baseline and you reduce ischemic burden, and this is the evidence, that your prognosis will be better. Specifically for CTO population, and this is a paper by Aaron Grantham, if you don't have ischemia at baseline that much, your prognosis will not be altered. But if you have a large ischemic burden at baseline, your prognosis might be altered. Again, non-randomized trials, but it does give a hint towards the fact that if you select your patients properly based on symptoms and ischemic burden, and you offer them appropriate therapy, not only will they have better quality of life, but perhaps even may improve longevity. We see this from pooled data. If you have patients who are not revascularized in terms of CTO patients, as opposed to them who are, prognosis seems to be, cardiac death seems to be a lot less. Again, non-randomized trials, and this is in the absence of randomized trials. One of the few randomized trials is Decision CTOs, published in Circulation in 2018 or so, which did not show any benefit for revascularization of CTO. This is a multi-center trial from Korea, which included multi-vessel disease in a lot of patients. And it just basically goes to show that PCI-CTO does not improve outcome, which in itself is not necessarily bad or surprising, because the fact that we've never shown PCI in stable coronary disease to improve outcome. It does have improvement of quality of life. In incidental cases, it may improve outcome, but for the population at large, it probably doesn't. So CTOs are in that respect not a different animal. We've seen this from pooled data, and this is one we just pulled from the Netherlands Heart Journal. This is a sort of a busy slide, and I won't go into detail because it's just a few slides that of the randomized trial that's out there. Explore, EuroCTO, the REFAST, the Decision trial, basically showing that you will not essentially prolong patients' lives based on CTO PCI, but probably you will improve their quality of life. This is not new. We've known this from the COURAGE trial. These are 15-year-old follow-up data from the COURAGE trial published in New England Journal of 2015, showing that optical medical therapy are equivalent to PCI in stable coronary disease. And CTO is not different from stable coronary disease. Actually, it is stable coronary disease, just in a more advanced form. So guess what? It's true for all PCIs in stable coronary artery disease. We know this now from the ischemia trial, even though this is a flawed trial. They tried to establish a large ischemic burden in patients, whereas only 25% of the patients included had large ischemic burden. So this is still open for debate. If the patients with a large ischemic burden do not benefit from percutaneous coronary intervention, but it hints towards the fact that still, if we do PCI, if we do invasive therapy, it should all about the patient. It should all about be quality of life. Less than 25% of the ischemia patients in ischemia trial had more than 10% ischemic burden. So recovery function, yes, there is a little. If we take a look at this pooled data from Huber et al. Published in the International Journal of Cardiology 2015, you get some restoration of LV function, but don't kid yourself. If you have an ejection fraction of 20%, you're not going to go to 40%. If you have 30, you may go to 35, and that may be the threshold for you to get an ICD, yes or no. So it's important to realize what your expectations should be. It's not that big of a difference, but it might be just a difference for the patients from heart failure to non-heart failure, from ICD to no ICD. So that's important. Don't expect great LV improvement. We know that from the Explorer trial, one of the few randomized trials, that if you encounter after a STEMI, a CTO, don't try to open up, don't rush your patient to the cath lab. If he has a STEMI and a CTO, don't rush your patient to the cath lab. It's not going to work. Right after STEMI, no effect. Let the patient heal. It's pretty much the double jeopardy concept in hindsight. You should have opened up the CTO prior, not behind the STEMI. It's not going to work for you. It's not going to work for your patients. Also, if your patient has no symptoms, he's not going to improve. If your patient has symptoms, he is going to improve. So again, circling around the whole concept that stable coronary disease is about symptom relief. It's like hip replacement, cataract operations on the eye, whatever. If your patient has symptoms and you can alleviate it in your best center, you should do it in the best of care and the best of patients, because your patients will be able to run that marathon again. That's very important. Symptom driven. So this is not just my opinion. It's been proven by Gerald Werner, who published the EuroCTO paper in European Heart in 2018, that patients as opposed to placebo or placebo to non-treatment do have a better quality of life. So treat your patients with quality of life. If you have a closed artery and you have symptoms, open it up. And if you can't do it, refer to somebody who can, because those patients will live better lives. It increases quality of life. So appropriateness, and this is a slide by Alfredo Galazzi, the former member of the former president of the European Society of the CTO Club and published in European Heart. It's very simple. Presence of symptoms, yes. Normal LV function, yes. Big artery, yes. Open up the CTO. You have no further incentive. You do not need any further imaging. Only when things get rough, like LV impairment, a lot of comorbidity, and you don't know what to do you end up in this end of the scheme. But half of our patients are in this scheme. No imaging is needed. If LV is normal and you have a symptomatic CTO, just open it up. And if you are not able to do it or willing to do it, then refer the patient to someone who is. So in conclusion, I'd like to state that CTOs are the most advanced stage of coronary artery disease. Treatment is not simple. We all know this. But PCI CTO is equivalent to obstructive coronary artery disease, which we do all the time. It's just more difficult. So if it's more difficult and we cannot grasp it, we need to learn or refer. Aim at symptom relief, not longevity. That's a myth. Build a program or refer. And I'd like to end a quote by Yoda, who says that we should do or do not, but we should not try. Thank you.
Awesome. Thank you so much, Paul. That was really, really great. I think we'll save the questions for the end of all three speakers. But I think your message was loud and clear. And with that, I will try to see if Dr. Smith is in the house and he's ready to take over.
Dr. Smith is in the house.
Great. Good to see you.
Good to see you too. Good to see all of you. Nice to see you, Paul.
Hi.
Good as always.
Good to see you.
So you missed the introduction, but again, we're very fortunate. Yeah, we're very fortunate to have you, and we look forward to hear your talk, and we look forward to see you here in Israel. So if you're ready to go, you can share your screen. And
fantastic. Let's do that. Let's do that. Okay. Good stuff. So hopefully you've got that there, have you, sir? Yeah,
we're good. Go ahead.
Fantastic. All right. Well, firstly, thanks very much for the invite and to connect with all of you again. It's been far too long, but looking forward to hopefully visiting very soon when things open up again. So the title that I'm going to speak to is CTO Toolkit, specifically for the non-CTO operator, and the key innovations that are changing routine practice that are trickling down from the CTO space into our routine everyday practice. So there's no doubt that innovations have changed CTO practice, and that's from antegrade wiring through to retrograde procedures and the ability to do dissection and re-entry. But in order to be successful, we've had to learn a huge amount about guide catheter support, about choosing the right sort of wire, and a lot about microcatheter technology. And it's really these areas that are changing our non-CTO practice today. So I am going to speak to wire technologies to some degree. I'm going to talk more about the evolution of microcatheters, and in particular, dual lumen microcatheters. And I want to spend a little bit of time talking about advanced guide support and trapping solutions. But the key is to understand that this is not a shopping list. Each technology enables a strategy. Each strategy requires a skill set. And to use these technologies, you need to understand, learn, and utilize them. And then you need to learn how to combine these skill sets. So one thing we've learned in CTO is to have a lot of forensic procedural planning. So we think about guide support before we start to do the procedure, the size and whether we're going to need a guide extension and what type and size that might be. It's about having the correct wire to be used at the right time in the right order, and that means the right availability. And in terms of when we're using microcatheters, we're using microcatheters not just to change or reshape our wire, but for support of our wire, for crossing profile, and in some cases for penetration, crossing and dilatation of the lesion. So let's have a look at a case. Here's a complex PCI procedure. Potentially, this is a patient who's unstable, turned down for surgery, severe multivessel coronary disease, dense calcification, a bifurcation in the LAD, osteal disease, and to top it all, it's a dominant circumflex with a critical stenosis in that circumflex. And when you look at it in terms of procedural planning, you may say, well, look, I'm going to think about shockwave, I'm going to think about rotational atherectomy, but first you've got to cross the lesion. And the question is, how many of you would usually take a microcatheter to start this case? Well, in the area of CTO PCI, I certainly would, and I'd use my workhorse coil design microcatheter, which in my lab would be a Corsair Pro 135, but it might be a Turnpike. This is a microcatheter that you advance through rotation and push, and it will not only penetrate the lesion, but it may potentially dilate it. But here, I've been able to wire the lesion not with a workhorse wire, but with a Fielder XTR wire because it was so tight. So we've used a tapered polymeric wire to try and get through, but I can't actually follow it with the microcatheter. So what next? Well, we can either enhance support or facilitate crossing. So by enhancing support, we can change the guide catheter shape or size. Well, we're already 7 French, or we can use a guide extension. But in this case, that would promote ischemia across the whole left ventricle. We can use anchoring balloon techniques, which we've learned from CTO, and I'll show you that in a moment. And you can change your wire to a dedicated support wire or use a buddy wire, but here again, that's not relevant until you've crossed the lesion. So in this case, it's facilitating crossing that we're going to concentrate on. We can use a lower profile microcatheter or a penetrating microcatheter, or we can change out to an ultra low profile balloon. Destination therapy here is going to be to modify the lesion, but for that we need to get that rotor wire delivered. And of course the two things aren't mutually exclusive. You can enhance support and facilitate crossing at the same time, depending on the vessel and lesion characteristics. So here we see our stalled microcatheter. So I changed this out to a specialized penetrating microcatheter. You can use either Turnpike Spiral or Turnpike Gold, and you can see that in addition to its coil design, it also has these external screw features on the outside of the vessel, or of the outside of the microcatheter, that enables it to penetrate and pull itself through the lesion, thereby crossing and delivering your wire. But that won't go either. So now I go back to the old-fashioned anchor option. Balloon 2.0 in the septal. That allows me to drive a 1.0 sapphire balloon down through the lesion. That allows me to progress the microcatheter further in order to then pass the rotor wire. And once we've got the rotor wire there, first burr, second burr, and then we can go on and fix the case and go on and fix the circumflex as well. You have to understand how your microcatheter is made in order to use it properly. The coil designs have these rope coils around them that mean that they're good for rotation as well as advancing, and they will dilate, but they'll tend to be a larger profile. The lower profile catheters such as Caravelle or Fine Cross are braided, but you can't rotate them, and if you do, you can potentially damage them or twist off the tip. So it's important to understand which microcatheter you're using when. How do we progress these microcatheters? Well, I'm just going to show you a brief video in a second if I can. I'm just going to stop the share for a second and change to, in fact, do you know what, we'll just move on from that. We'll just move on because there's not enough time. If you're going to use microcatheters, it's really important to know how to use a trap balloon. So if you're going to progress a microcatheter through a lesion, then you change out your wire, you're then going to need to change over the microcatheter to another balloon, and that means trapping the balloon inside the guide, trapping the wire inside the guide so that you can remove the microcatheter safely and so that you can move to the next step. If you use a dedicated trap balloon, then these will make sure that they never exit the guide, and making sure that you then are safe and that you're never going to traumatize your vessel with a balloon that you've put through the guide, but without it being on a wire. This is the IMDS solution from Abbott, and this is the Boston Scientific Trapper solution, which has got a collar to prevent that balloon from exiting the guide. And because it's not on a monorail, this particular balloon means that you have more space inside your guide so that you can use the technologies that you need to use with more freedom. What about enhancing support? Well, you're all familiar with the concept of using a guide extension. Here's a balloon uncrossable lesion in the middle of the night that then is put on my list the next day to try and cross. We've used a more supportive guide, so we're using an AL guide. We use a cyan blue wire, and actually with a cyan blue wire and a microcatheter, it just crosses the lesion, and we can cross with a turnpike spiral, as we've already said. But then in order to treat this, we then put through an extra support wire, and then we use sequential balloon dilatation and a guide extension. And the guide extension allows us to give extra support in order to deliver equipment. But even with this, you can see that when we try and pass the stent, that we're not actually able to get through the lesion. So this is where some of our CTO techniques have enhanced our ability to use guide support. We can actually bring the guide extension far further down by using a balloon tracking technique. So here we have a 2O balloon within the guide extension, and we push those together as a unit. Or you can inchworm down the guide extension by using sequential balloon inflation and deflation to pull the guide extension through. But sometimes what you can do is put a distal balloon up within the lesion and then just pull on that balloon shaft to give counter traction, and that will enable you to push the guide extension deep into the vessel, and that allows you to then deliver a stent. Now, if we're talking about enhancing support as well as being able to trap simultaneously, there is also available the trap liner. And that's particularly useful if you've got multiple catheter exchanges. So it's different to a normal guide liner or guide extension because it's a shorter guide extension. Here it's only 13 centimeters. That allows us to have a built-in trapping balloon, and the push rod is actually a hypo tube, so that you can push this device deep into the vessel, but then trap out your over-the-wire technologies at the same time. And that's very important if you've got to facilitate multiple exchanges in difficult cases. Here's an example of a long occlusion within a previously stented CTO. And you can see that we've got a microcatheter and a wire and deep engagement of the guide extension. And then we're able to get through into the distal vessel. We exchange that balloon for we exchange the microcatheter for a balloon, then we exchange that balloon for a dual lumen microcatheter. The dual lumen microcatheter can then be exchanged out, and we can pre-dilate with kissing balloon dilatation, all while maintaining the position of our guide extension and without ever having to try and have balloons and microcatheters and a trap balloon as well as the guide extension all at the same time. By having it as one unit, it really can facilitate procedural efficiency and get us to a far better result. But if you're going to use these advanced guide extension techniques, you need to understand the risks involved, and you need to understand that we can't inject under pressure when we're deeply engaged. So it's very similar to the CTO in as much as we rely a lot more on fluoroscopy rather than giving injections of dye. We want to avoid ischemia. We accept that there may be pressure damping, and we know that these devices can dissect the vessel. So it's very important that you are prepared to fix as much of the vessel as you potentially traumatize with these devices, albeit if you pre-dilate well, that should be rare. And you need to look out for thrombus. So you must always be checking your ACT. So I'm going to end by talking about dual lumen microcatheters. Dual lumen microcatheters really were something that was desirable, but I think now in complex PCI, not just CTO, they're essential. They're especially helpful when you're trying to deal with bifurcations, making sure you don't go behind a stent but through it. They're very good at enabling you to wire difficult bifurcations. And in the CTO space, we use them quite commonly to provide more support when we're trying to puncture a very resistant proximal cap at the point of a bifurcation. There's a number of them on the market and they vary according to their crossing profile. I think the Sasuke and the Crusade will be the lowest crossing profiles, and also the angle and the position at which the wire exits. But the bottom line is that they are incredibly helpful in performing complex PCI. But in order to use them, you need to be familiar with your trapping techniques. Here's an example that I borrowed from Joe Dens, who kindly sent me this along. This is a reverse wiring using a double lumen microcatheter. The reason I show it is not just that the technique is really good, which is that you have a very rolled over wire that you deliver beyond the bifurcation that you want to wire, this retroverted takeoff, and you use the dual lumen microcatheter to deliver it. Then you bring back your dual lumen microcatheter and you start to wire the vessel. And as you bring back your wire that you delivered rolled over, you can see that it starts to make progress into that bifurcation until eventually you can actually start to drive it forward. But at this point, in order to maintain both of those wire positions, you're going to need to be able to trap out your dual lumen microcatheter. And because you're through the side port as well as through the over the wire port, the resistance when you trap it out will be greater. And also you need to know the length of your dual lumen microcatheter in order to make sure that your trap balloon is in the right position. And if you're using a Sasuke, because it's 145 centimeters long, which is longer than average so that we can use it retrogradely, that means that your trapping balloon needs to be further on, or that you might need to use some form of docking wire or extension wire when you're taking it out. So the key here is that yes, you can then trap in your single lumen microcatheter. So these are all techniques that we've learned from CTO applicable to a bifurcation. So now we can drive through a single lumen microcatheter because we've trapped that back in order to then fix this bifurcation, balloon it and stent it effectively. So a deep understanding of these techniques that have been learned from CTO will get you success in these sorts of cases. So what do we need inside the inside the non-CTO toolbox? Well, I think that you need a group of wires, and if I had a chance to show my live edited case, so I apologize for that not coming up, I'll be able to show you that you need a combination of polymeric tapered wires such as Fielder XT, XTR, to be able to get through very tortuous calcific lesions. You may need something that's penetrative and steerable, like a Gaia second. And I think you do need extra support wires along with your workhorses. In terms of dual lumen microcatheters, I think it's essential to have a workhorse coil 135 microcatheter for doing your difficult crossing procedures and also to change out wires when you need to. I think you have to have a dual lumen as an essential microcatheter as well. In terms of lower profile catheters, it's great if you can have either a Caravelle or a fine cross as well, so that you can go through the lowest profile lesions, but not absolutely essential. And depending on the maturity of your CTO program, it may be helpful for one of your CTO colleagues to join you for the difficult to cross lesion to use one of these penetrative microcatheter options. In terms of guide catheter extensions, well, they're ubiquitous and you're always going to have them in 6 and 7 French at least. I think you should start to think of in non-CTO PCI using dedicated trap balloons. I think they're extremely helpful. And if you're familiar with those, then you can start to think about whether in isolated cases, trap liner can be helpful. It's certainly helpful in CTO. So I'm going to stop there and say thanks very much, and then we can take some questions.
Great, Elliot. This was really beautiful, and it really hit the spot. I'm sure that our audience, at least some of them are not CTO operators, and as a non-CTO operator, I learned so much from my colleague, and I thought it would be advisable and worthwhile to show how these techniques are applicable for any interventionalist, as long as you know what you're doing, and as long as you have someone at your side to at least show you how to do some of the stuff that at least at first looks so complicated, but basically if you know what you're doing, they're not. So now I think is a good opportunity to reintroduce Ilya Litovchik. I think we know each other from somewhere. And I think this would be our last talk, and then we'll have, I'm sure, a quick chat. And I thought that Ilya will give us a quick brief on how to initiate a CTO program. So Ilya, the floor is yours.
Okay, thank you very much for the introduction. I will share my screen now. A moment, please. It goes like this. Here we are, share. Can you see it now?
Yeah, you're good.
All right. My short talk is nuts and bolts of a CTO program. My introduction to the CTO program was done by these two guys, this Mori Carlino and Sunao Nakamura, a long time ago. It was a pretty big deal to bring this idea, this agenda to our cut lab, because we had to break some old habits that we had in the cut lab. The CTO is not just another complex PCI. It should never be done ad hoc manner. It should be done with special equipment and special technique, and the complexity doesn't negate necessity, as Paul highlighted in his talk. First steps were to concentrate the process in the hands of one operator, to launch CTO clinic, because you need patients, to equip the lab with the relevant CTO tools, adopt hybrid algorithm, and what was very important, to convince and get support from superiors. So by fortune, my superiors were and are very supportive. It's a good opportunity to express my appreciation, and it was very, very helpful. So first tip, and will be the only tip in this lecture, what will bring you to immediately improve the success rate is just to adopt the hybrid approach, this dual injection.
Ilya, can you speak louder, please?
Yeah, sure. Yeah, sorry. Dual injection with longer sheath and large bore catheters will improve your success rate immediately. So there are four concerns for the beginners. The budget concern being over budget, the occupancy of the room, complication, and how to deal with failures. The budget, your average PCI toolkit is like this, is one access tool, catheter, couple of wires, maybe a couple of balloons and stand, and it costs this money. CTO toolkit is much larger. It's twice an access, twice the catheters, multiple wires, two expensive microcatheters, a lot of balloons and stands, and it's at least twice the price. And you have to know this and to get ready. About the room occupancy, you enter your CTO case and this MADA on its way with the STEMI case. What should you do? So in our experience, the procedure duration in our program is at average 105 minutes, just less than 2 hours, but there were also very long procedures, like 4 hours with complications. But still, what is most important here, you have to create a condition for quiet work. You cannot be on rush, you can't be on hurry, never. So you have to plan your procedures. And the CTO procedures may be and must be time limited. So you have to plan when to stop. One of my teachers learned me that the thing that will not succeed in 2 minutes will never be done in 2 hours. So you should fail fast and move forward. Yeah. So complications. Complications is a very tough but very interesting and challenging thing. There are different complications. A couple of them I can show you. Vascular complication. Any complication, you have to decide whether it will be a go or no go for the continuation of the procedures. Some complication will not hinder the performance of CTO. Like this case, it was a vascular access complication with the dissection, but we managed to put a wire from the other side and it closed the flap, and we just finished the case successfully. Moment. This is a catheter thrombosis, just injection during the initiation of the case, a set of images, thrombus just been injected into the stent, prompt solution with a balloon, and wire was, artery was reopened. We managed to proceed with the case. There's another sort of complications. There's a collateral injury or damage. There's a dissecting hematoma at the tip of septal collateral with, you know, the spillage of blood in some chamber somewhere. We cannot proceed. We have to reverse the heparin and to stop. This is a very interesting case. It is last image. It is the last shot. Okay, the stent is in place. All is fine. And this was a complete surprise. So we have to be able to tackle it promptly with papyrus or some other covered stent. Sometimes you have a complication in the situation that is very tense and very unsuitable. We are prepared here for reverse cart. We've done all the way around the heart. We're okay, but suddenly the patient became hypotensive, occlusive balloon. When hypotension arises, immediate suspicion of tamponade, so we have to act promptly. We performed a very fast pericardial tap, removed the blood from the pericardium and injected it back to the artery. So one thing that surely we had to stop. A couple of hours later, it was a dry pericardium, no fluid. So it was very fast and very dramatic, but successful. Surely enough, we can proceed with the case. I beg your pardon. All right, failures. Failure is a very frustrating thing, but there are two different types of failures. One type of failure is like this. We, again, made all the way around the heart, approach to the ostium, ready for externalization, but we couldn't manage to cross this short segment by no way. So it was very frustrating, but never mind. A couple of months later, we performed another technique, just externalized into aorta, and then grasped the wire with the snare, and then managed to recanalize this RCA. It was very nice. Another type of failure is a dead end, this total loss, let's say. This post-CABG patient with a couple of branches in the ischemic region and instant restenosis, recurrent instant restenosis in the single remaining marginal branch with the closed included VG graft. So we managed to revascularize. We performed a very nice ipsilateral collateral surfing, managed to re-enter the artery, approached to the catheter. It's 1 millimeter from externalization. The next move, for unexplained reason, I just pulled the wire out. I was unable to rewire this artery again. So I had to end this case with only POBA to this marginal, and the case is done. It's no way to get back to these small arteries. So most of good stories in the world are stories of partnership. So our story, a CTO story, also have to be a story of partnership. You have to find a good partner. Why need a partner? A partner is one who can help you in discussion and planning of the procedure, assist you, support you when you're down, support you in failures, support in troubleshooting your complication, and setting things in order. It's just an example of my partner, one of my partners. My partner is Dr. Sar Mincha, forever. This is an order in our cath lab, and he's my co-pilot. Looks like this. He's not obsessive, he just loves to put things in order. So you have all the blocks for the building. Now you have to move and to start the process. Japanese philosophy postulates that good process creates good results. So if you want to get good results, you have to invest in process. Our process is built of 4 steps. We first assess the history, symptoms, and optimizing therapy of our patients. Then step 2, we make an assessment of ischemia and viability, and we also deal with the complexity of lesion. We assess it by different scores. We make a discussion, and then we plan the procedure and explain it to the patient. Third step is intervention by itself. And fourth, which may be the most important step, is the assessment of early and late result. We learn from the results of our work. So we've done in 3 years, we saw 166 patients that were referred. Surely now there's not all the CTO patients in our lab, because most of them were not referred to the clinic and the patient that we saw were the patient that operator thought that they are eligible for PCI, let's say. But we advised only 129 procedures. We treated 103 patients, and CTO attempts were performed in 111 cases. There's a majority of male patient. Most of them has previous coronary artery disease intervention in cabbage. Most of them are stable angina. The most common ischemia test is SPECT. Most of them are multivessel disease, and RC surely is the most common target. The program is growing. It is, for me, a very good result for a beginner like me. It continues growing. We successfully recognized 83% of patients. I think it's also pretty good for a beginner. I can show you also the complexity, JCTO score that is constantly rising along the way. So we're performing procedures in more complex cases. We utilize a hybrid algorithm. We do dual injections routinely, or in most cases, and 1/3 of cases are revascularized by retrograde approach, including reverse card. Complications, we report all the complications that we encounter during the procedure or after the procedure, immediately after the procedure. Most of patients end up without any complication. There were 5 CTO perforation, and we performed the one and only pericardial synthesis. Nobody had died during the procedure, fortunately, so far, to touch wood. In 7 days, we've got 7 cases of myocardial injury. We are guided by the guidelines for clinical trial design principle CTO ARC, which was recently published in February, in my opinion, for reporting the complication rates. So we have a 7 MI, 3 pericardial effusion. We have only 3 acute kidney injury. 1 patient had died during his hospitalization a couple of days after procedure. I don't know the case. Don't know the reason of his death, but it happened. Outcome. First of all, I can show you the angina. This is baseline angina, okay, CCS score from 1 to 4 from the basement, which improved significantly. In 78 patients, we have a follow-up in 30 days, and 53 patients, we have follow-up in 1 year. They all improved. Outcome, a bit busy slide, but most of them have uneventful recovery, 30 days. Some of them had unplanned hospitalization and recurrent on unplanned PCI. About the PCI, in 30 days, there were 6 cases in 30 days. 3 cases were connected to the target lesion or vessel, and de novo were 3. And in hospital or early mortality in 30 days occurred in 2 patients. 1 was in hospital, I've mentioned that, and 1 patient unfortunately died from pneumonia. In 1 year, again, uneventful recurrence, only 53 patients so far. Uneventful recovery is the most common. There were another 7 unplanned PCIs, and this is numbers, and another 4 patients died. So there were 2 presumed to be 2 CV deaths and 3 another non-CV death. We moved forward. We opened and expanded the registry of Israeli CTO collaboration for a couple of centers that perform CTO cases. 3 centers are already active. 2 centers got approval of ethic committee and are ready to go, and 5 are making paperwork to get ethics and to approve and accept the protocol. They have already 158 records. There are 156 CTO procedures. Most of them are planned with dual injection. 89% are retrograde, and successful rate is 80%. So for beginners, again, it is, in my opinion, it's a very good result. So how to build a successful CTO program? I think that if you start with a commitment and you have a head for innovation, you manage to deal with the budget and occupancy issues, you know how to tackle the complications, and how to deal with your failures. You constantly improve your technique, you learn, and have a very good partner, and you build a good process. I think you'll succeed, and I sincerely wish to everyone to succeed on this way. And thank you very much. Thank you for organizers and my teachers and friends, Professor Paul Knaapen and Dr. Elliot. It was a pleasure and privilege for me to participate in this webinar.
Great, this was awesome.
Thank
So
you.
I think we have some time, because I guess that we've covered few topics. We covered from last to beginning. We covered how to start, how to initiate a program, how to use the CTO toolbox in your daily practice, and whether, and I'm sure now everyone is convinced that there's enough evidence to support performing CTO by expert. Now the floor is open for questions, and you can just unmute yourself and ask questions. And if while people are getting in, or hopefully will ask questions, I want to ask our 2 distinguished guests from abroad if they would have a few tips like Ilya gave for initiating a program. Who shouldn't, how to start it. Let's start from Paul and then go on to Elliot. Just in a nutshell, what would you advise?
The answer is actually quite simple. First of all, you need to engage. So you need to build a program with people who are enthusiastic and are willing and able. The operators should not be novices, and they should really have a heart to build such a program. So step 1 is double arterial access, manage antegrade wire escalation. Once you've done that, retrograde procedures. This could be done easily in like 2 or 3 months after your wire escalation scheme. Start simple with retrograde wiring. If you've managed retrograde wiring usually means reverse card, so you automatically end up with dissection reentry. Once you have dissection reentry, you'll move on to antegrade dissection reentry. It's not rocket science, it's not brain surgery, it's coronary intervention. But I've been to your lab multiple times, and I think you're exactly how I and Alex did it in my lab. It's the entire team with enthusiastic people with dexterity who are willing and able to go. But it's just a few steps: double antegrade, a double injection, antegrade wiring, learn how to get retro, learn how to dissect, and that's it.
Perfect. Elliot?
Well, I'd echo everything that Paul says, and I definitely agree with the order that you want to get your wire skills up, then you want to do retro, and then you bolt on ADR when you're really comfortable with your retro. I think that's the way to do it. In terms of engagement, I think one of the things, if I could go back in time, is the sort of them and us feeling that somehow you're a CTO operator, and so you sort of, I can do it and no one else can do it. And that does leave people behind. So I think the engagement is really important. And what we've learned over the last few years is that if you set up and I like Ilya's process there at the selection stage, having as much engagement as possible. So you can build in a complex revascularization meeting. You don't call it a CTO meeting. It's a complex revasc meeting where we all can bring our difficult problems to try and decide, firstly, can we offer anything? And the best friends that you will make from those meetings will be the surgeons, because they do not like doing restenotomies. And a very large increasing proportion of the work that I know Paul and I are facing, I mean, probably up to 50% of my work is post-bypass patients. And they have a lot of opportunities, even though they've got a lot of complexity. So you bring the surgeons on board, but also those people that are flying outside that still are have-a-go heroes who are having a poke and hope. They really can't afford to keep doing that anymore, because they see that there's someone else in the institution that's got better results. And then you can set the parameters of which cases a more junior antegrade operator can do, which is JCTO01, fail fast, refer quick. And when you're operating, your fail fast, change strategy quick. So I think that engagement and having a complex PCI or a complex revascularization program within which a CTO program sits is the way to do it within institutions and between them.
Ilya, do you have anything to add? I mean, before Ilya, I think that I'm now speaking not as not as a CTO operator. I think because I know that there are some decision makers as our listeners. And I think, again, this is also one of the commitment. I mean, if you want to go forward with this program, you have to support it from day zero, not only with resources, but with referral. I mean, everything, the system needs to be tuned to assist and provide the facilities, the budget, and the commitment to support this program. Because in our environment, which is very, very, let's say, money saving environment, probably like most other environments, but especially in Israel, it is a problem. And I think that as a decision maker, you have to make the call whether you're engaged as a senior executive in this program and you go forward with it and don't stop it. I mean, if you go forward with it, go with it. If not, just refer the patient to someone who does it. I think that would be my 5-cent tip. Ilya?
I think that the referral basis is very, very important. And I think that the most important step that we done, we started with the clinic, we started with the patients. So this process is about your proficiency, one, and your patients. You have to treat patients. You have to create a hub that other operators, surgeons, or doctors would refer their patients with their complex cases to your treatment, to your assessment. So I think that talking about the proficiency, we have also to speak of the patients that would stay with you, and not all of them would undergo procedure, but all of them should be managed and followed up. So if you if you want to start, I think in the parallel with your personal development, you have to build a large clinic with a lot of patients and invite other practitioners to refer to you.
Cool. So I don't see any questions on the chat, and I didn't get any worried WhatsApps. So I wanted to thank again for all the participants, for all our speakers, Professor Knaapen, Dr. Smith, Dr. Litovchik. This, for me, it was a really great evening, and it was great to have you all here. Hope to see you soon in Israel, and to see you again in our lab. And I think that if you need any other information, I think this group and other people can definitely assist, and I'm mostly willing to assist. And again, we want to thank MedPoint, Reuven, Medtechnica for all their support. This is very important, and none of this could have happened without you guys. And of course, the guys באיגוד. אז תודה רבה, ערב טוב. Thank you all and have a great night. Purim
Thank you very
Sameach.
much.
Thanks very much. Take care, guys. Purim Sameach. Enjoy.
Thanks. See you soon. Bye.
Bye-bye.